You semua ada dah?
Not yet, Doctor.
Not yet.
Another 3 students. Dato, all members are already here.
Assalamualaikum Dato.
Ada semua dah?
Yes, okay. Already, our member are already in the meeting.
Semua on muka Tengok semua ada tak? Mana you ni? Process fish. Mana ni? Ya. Semua muka nak tengok. Ada tak ada? Teknis mana? I know. Muhammad Ikram mana? Ikmal. Ikmal. Orang tak ada muka consider tak hadir. Ikmal.
Yes, doctor.
Mana muka you? Mana Ikmal? Tak nampak muka pun. Suatera ini. Ikmal. Muhammad Ikmal. Ada tak dia Ikmal ni? Siapa hit off ni?
Yes, ada. Okay.
Ikmal banyak report saya grup tak tahu dia orang ni.
Tak ada pula orang ni. Tadi ada. Sekejap tu Aish.
Dina ada tadi? Dina, ada muka dia tadi kan? Dina? Dina Zawati. Dina ada tak? Dina?
Ada doktor saya.
Buka awak. Ikmal tadi buka ya, Ikmal ya. Siapa HOD tadi? Head of group tadi?
Saya doktor.
Itu mana? Tanya Ikmal mana dia?
Ikhwan saya dah WhatsApp dia. Dia pun single tick. Nanti saya call dia sekejap.
Nak start dah sikit ah.
Doktor, saya pergi bilik dia sekejap, doktor.
Nah. Boring lah kena buat benda macam ni. Semua dia bagi trust deficit. Ya Allah, 23 dah. Jadi 23 dah. Ada orang 22 dah kerja dah. Ya suka ke benda macam ni? Dah chat semua.
Sorry doktor, I've already called him, but not answered.
Lah kau sendiri tak datang lah. Tahu. Okay, we are talking today. You're still taking, yeah? She's still talking. Is she taking? I'm going to tell you mainly a rough a guideline of what the history, the main content of the history in pediatric. Keep in mind of that. There's no such thing of.
Isma tu ada problem dengan wifi.
Okay. Problem dengan
Wifi mahal lah, dia tak boleh connect.
join lah pergi bilik you all.
Okay.
So tunjuk muka dia. Okay. So there's no such thing of everything fits for everything. Yeah. See what we give you a guideline, a general content, and your job is to adapt it. How each patient will have a different, its own peculiarity. So don't take things are the same for everybody, but the general rules are really the same. Okay, the rules are the framework are the same. What I'm giving you is a framework. What you have to understand is the key framework, because usually if you fail to have this key framework, then your presentation or the way you thinking process also will be a problem. And then not only that, we really not understand what you think. That's why we need this you to understand the framework. So first of all, you have to this is what we call clinical skill. You have to understand what clinical skill is that. What clinical skill is: history, physical examination, diagnosis, investigation, and management. That's what we call your clinical skill. This is what you're going to learn in your 3 years. And the first 2 years, you learn the non-clinical skill, your basis, the root of the medicine. This is very important. Because if you have your basis of clinical, your basic science are good, and then you can develop your clinical skill on that. It's a root. Remember that it's a root. So if your root is not good, definitely the pokok, the batang, everything semua not going to become good. So you must realize that what you're doing is that building is to build on the first 2 years of your medical school. So this is not to say this is the most important. Everything is important. Sadly, many of you after the first 2 years, you just forget the basic science, and then the result is that you unable to tie up between your basic science knowledge and the applied knowledge. What you're learning now is application, not a basic science anymore. So the set of clinical skill include the history, physical examination, diagnosis, investigation, and management. And then your year 3, what you focus is taking and present the history, to present the history. That is your main. Then able to do the proper physical examination, making a diagnosis, and planning for investigation. You can learn a little bit roughly about investigation, but that's not your main point. Your main point is to know how to take history, do physical examination, doing physical examination, making the diagnosis, and planning for investigation. So as you know, your basic knowledge based on anatomy, physiology, biochemistry, pathology, microbiology, and pharmacy. That is very key. What you are doing now is you are going to apply what you have learned during the first 2 years, and then you apply it to your patients. And then because the 3 years training the clinical training is to set your mind how to think as a doctor. You see, if you are experienced enough, you can talk, you can sit in front of a lawyer. The way they talk, you can figure out, oh, this is a lawyer. The way they talk you can figure out who are they, because this is how they've been set, their mind been set, the brain synapse have been formatted. The key 3 years is to format your brain synapse to become the way thinking of doctors. That's what we call professionalism. You have to accept that this is the way you are thinking for the rest of your life. Unless you decided that after a while you don't want to do medical anymore, you want to be businessman, still the way you have the peculiarity of you doing your decision making is a way to be influenced by the way we train you these 3 years. So clinical is about applications and patients, about your patient, because that is your bread and butter. So what is history? History is ability to extract history. That's the first thing. Ability to critically evaluate the history, the ability to present and communicate the history. So it's just not about history taking. You have to have the skill how to extract the knowledge, the history. You have the ability to critically evaluate the history that you have taken, and then you have to be able to communicate. You have to have this 3 set of things for you in order for you to able to complete your history taking. That's what it means. Just not a club patient only. It's also about the skill to communicate and evaluate the history. There's something many of you thought that taking history is enough already. It's not that. It's not that. It's a combination of 3. You must be able to do all these 3. And each of them is value equal. None is important than the others, all equal. So very important for you to have this skill. Many of you focus on the number 1 only, ability to extract history, but you didn't evaluate the history, and then you're not able to communicate and present your history properly. That is your setback. So you're focusing on the number 1. First of all, you have to decide in history taking when you will come to pediatric. Whom do you ask the history from? The best is always mother, but not always. Not always mainly mother, but sometimes caregiver, sometimes the patient itself, sometimes father or the siblings. They are good father, but majority father are they're not very sure their own child history, and sometimes the father history and the mother history are not the same, and so you have to be aware of that. I usually give high marks on the mother, on the mother history naturally, but not always. Naturally, the mother got high marks in terms of the history, in terms of the precision, the precise of history, the precision of history. And then the other thing you must realize in our context, when it comes to time, our culture very confusing. Even 3 days ago, 4 days ago, they're still unable to recall. Because you see, in our language, time is not the main factor in our language. Unlike, let's say, in English, they already past time, past present, past, and so on. Because in their culture, times are very, very important. That's why the English, if you want all the verb, they have a past tense, past present, and so on. Because for them it's very important. Unlike us, kalau past usually kita add sudah makan, kita ada ini kita add something else. Bila past kita KO dah, tak boleh go beyond that anymore. Because that's not our culture. So you have to realize, be particular of that when you clock your patient. That's why many of you when you present, I found out one of the main weakness of the history is about the temporal time. So what event occur after, and that what event after. Is very weakness, because I think the problem is you all also in the culture, you don't understand, you don't notice the weakness. The principle of history very simple in your mind. You have inside your mind in anything when, why, where, who, what, who, which, how. It has to be inside. When this happened, why this happened, where this happened, what is it, who do it, which part of it, how it happened. You have to have this. This is the weakness of these are the weakness of many of you. Because inside your brain, you don't have what we call investigative brain. Investigative brain is that you always ask yourself, any events, anything that happened, any particular things, when, why, where, what, who, which, how, we call W's. Always have what is the W's. Those who have this, mark me, they have an easy life when it comes to history. Those don't have this, you're going to be very difficult, because you keep asking yourself what to ask, what to ask, what to ask. But those who have this, they have no problem, because they know what to ask, how to ask, because in their mind, they already have, I don't know, during my time, I like to read any Blatant or those things, because this is the kind of, because of, apa, you suka baca buku apa? Tak tahu, tak ada buku. Pernah dengar ke any Blatant ni semua, pernah dengar? Tak ada. Buku-buku berkaitan investigation masa kecil ni, tak ada. The create how to investigate things. You tak baca semua buku tu. So that's why you have difficulty to know what, where, tak ada dalam fikiran you all. Second thing, chronology. Chronology is because times are very important for things to occur. Without time, nothing will occur. And there are sequence of that. So you cannot to tell us what happened before the next, what happened before you tell us what happened before that. It's going to be confusing, because very important for us to look into the chronological of event to tell us increased severity, getting better, the child become deteriorated. All this is related to time. Because it tells us, it can help with diagnosis, it can also help us in terms of how severe is it. So important that anything you have to have you have to have the idea of the chronological event of any events. Clear and logical. You have to clerk until you yourself clear and understand it logically. If not, you keep on clerking until you clear what's happening. Until you clear. Don't stop. Sometimes when I ask you back, you're also confused because you yourself not clear and understand logically. Right? So first thing of all is to know the chief complaint or chief complaints. But usually chief mainly one complaint, but sometimes can be 2, 3 complaints. The chief complaint depends where you are. The definition of chief complaint is that the reason patient come to see you, either you're in hospital, clinic, or wherever you are, there will be a reason or reasons why the patient come to see you. They don't just drop by suka-suka. That's for you to identify. The reason the parent bring the child to see you, to the hospital, like you, if you are learning process in the hospital, why bring the child to hospital? The child maybe have fever for 3 days. After that, develop diarrhea for 1 day. And the reason they bring to the hospital is diarrhea, not a fever. Or they went to go to other doctor for fever, doesn't work. Then after that, they come to the clinic because to the ward, to the EAD because of fever, then the chief complaint will be fever. So it can be, oh, what is it? Hello? Ah, kenapa? Hmm. Hmm. Biarlah datang dulu. Dia macam mana dia boleh pakai SIP 5. Dia berapa hari dah dekat situ. Tak apalah, kalau dia okey, kalau nak balik biar balik dulu. Datang 6 week lagi macam tu. 6 week atau 2 bulan sekali. You are busy kan? Full tak? So dia buat 2 bulan sekali, tak apa. So 2 bulan sebulan sekali, 6 minggu sekali. Nanti APVD tu apa? APVD tu apa? Okay, PVD, so no need I go for C lah. Tak apalah, I can help manage. The patient on CPAP kan, BPAP. CPAP lah. Okay, so dah lah dan sort out semua tu. Lagi? Patient tu pass away tracheostomy. Tak ada. Dia update very bad. We want to update the child getting very bad, but he didn't update me the child pass away. Aku pula tak tahu apa jadi, very sad. Apa benda explanation tu? Ya. Mortality bila present? Nak datang tak? Nak ke datang? Ya. Datang Malaysia present elok-elok. Nanti kan kalau datang present elok-elok. Nanti kan habis presentation ya. Okay, tak apalah. Dia HFOV ke ni? Yalah, aku rasa tak sebut so much, tapi tak try, boleh try sebenarnya kalau you rasa. He told me after that ARDS, like picture, the last picture, tapi so fast lah. Tak apalah. Okay. You okay, go back to chief complaint. So chief complaint, you have to identify. That is the key of important to know the chief complaint, because that is the key of your case. How do you think, how you plan your case, even how you want going to club, much depend on the chief complaint. If you are unable to decide chief complaint, believe me, you would not know how to go about the case. And usually if you are unable to, something is not right, if you are unable to identify the chief complaint or complaints. And most of the time it consists of symptoms. Fever, shortness of breath, sinuses, and so on. That's the chief complaints. And then the second one is HOPI, history of presenting illness or present illness. There are many presenting illness, how to present, or the present illness. So always, as I said earlier, when you come to this, the key is the chief complaints, and you have to decide when, where, why, what, and how. Any of the chief complaints. They say fever, when it start, where it start, why it start, what the fever cause, how do you, even if the child got seizures, you have to know when, where, why, and how. And then the chronological, the acute or chronicity, you have to decide acute chronicity, how severe is that? The fever is low grade fever, intermittent. Fever is high grade fever, persistent, different in severity. So are diarrhea. Diarrhea only 2 times per day, 3 times per day. The amount is moderate. But diarrhea can also be 4 to 5 times a day. It's watery diarrhea with a lot high volume, with a very little fecal material. Then it tells you the severity. Diarrhea for 2 days, diarrhea for 1 week, all of it a different implication and kind of different diagnosis. Diarrhea after eating something, or diarrhea because related with fever, all that have a implication. So very important to go through about the diarrhea, acute, about the symptoms, acute or chronicity, and severity. Every symptoms that been told to you, you have to assess in severity, especially chief complaint. The chief complaint is diarrhea. How severe is it? Chief complaint of vomiting. How severe is it? You have to ask that. You have to identify that, and then you have to note the positive history related to the chief presenting illness or negative history. Let's say diarrhea. Diarrhea, the child got diarrhea associated with fever. Diarrhea not associated with fever. So the fever can be a positive related history, or the fever can be a negative history. Both have the importance. Both have importance. Both have importance when it's positive, when it's negative. So you cannot just say to me, oh, diarrhea have fever. Then you present to us. But with diarrhea, no fever, you don't want to present the fever. There's no fever. It shouldn't be like that. You have to mention the diarrhea without fever also, because that connotation can have implication. So very important. Any presenting illness, then you have to realize that when I say present illness, the child may have a presenting illness like acute gastroenteritis, but the child can also have present illness like asthma. Asthma is a present illness because asthma is a chronic illness. You can have asthma for the past 2 years. So it present illness. It can be a diarrhea, it can be acute. Acute can be a presenting problem. Acute, I mean, it can be a 5 days, 6 days ago, and then he has no diarrhea before. So very important, you have to identify that. So history of presenting illness or present illness. Then you go to systemic review. The systemic review, you have to realize about 2 things. Systemic reviews go system by system. Okay, it can be part of HOPI. Because you want to ask something related to the chief complaint that you don't want to miss anything. Diarrhea, patient with weak lethargy. Oh, so it's very important. Weak lethargy is, don't put weak lethargy is a systemic review outside of HOPI. It can be part of HOPI because weak and lethargy tell us how severe the diarrhea is. But sometimes also you don't want to miss something else that not related with HOPI. Let's say the child got diarrhea, but at the same time the child got some pseudolitis at the back. It may be not related. It may not related, most likely not related. So it can be the disease, the pseudolitis can be a systemic review, but not related with HOPI. So that is when you put it outside of HOPI. HOPI can consist of, HOPI is anything that is related with chief complaint. If you got HOPI diarrhea, anything related with diarrhea is a HOPI. Let's say patient got shortness of breath, anything related with shortness of breath is HOPI. That is the rule. Keep in mind of that. Don't separate it. After you finish your HOPI, then you go for the other histories, to complete history taking. What the other histories, like past medical history. Remember, past medical history or any history that the patient has that not related with HOPI. That is past medical history. The patient already recovered or still ongoing. If the patient having, let's say, asthma, so patient was admitted 4 years ago because of asthma. It is still an HOPI. But if patient got asthma, but patient have been admitted 2 years ago because UTI. So is it related to HOPI or not? Let's say the chief complaint is shortness of breath. Shortness of breath. The patient got asthma 4 years ago. Patient have shortness of breath, asthma 4 years ago. Admitted because asthma 4 years ago. Is it related with HOPI? Related or not?
No, I think.
Not
related.
Yes, got it.
Yes.
Yes, it's related. Because asthma can cause shortness. Most of the main presentation of asthma is shortness of breath. So the history of asthma will be in HOPI ke in past medical history. HOPI. Let's say the child got shortness of breath, admitted because UTI 2 years ago. Let's say got shortness of breath, having UTI 2 years ago. So you think the UTI related with shortness of breath or not?
No.
Not related. So where the history of UTI going to be?
Medical
History. So that is the rule. There is this the idea of that, the framework. So anything related with HOPI will be inside anything related to the chief complaint will be inside the HOPI. So birth history, including antenatal history, sometimes even birth history can be related. Let's say patient got birth asphyxia, seizure at the age of 1 year. The cause is birth asphyxia. The child got CP because of brain injury, because of birth asphyxia, come to see you at the age of 1 year, seizure. So the birth history will be related to chief complaint or not?
Yeah.
So you will be inside the HOPI. But let's say patient having 5 years ago shortness of coming with shortness of breath. But patient have admitted because of meconian expression syndrome masa dia lahir itu. Tapi the child is well until 4 years of age coming with shortness of breath. You think related or not? Not related. So the history of birth, the history of antenatal will be under the birth history and antenatal history. So to decide where is it going to be is you have to go based on the chief complaint. Feeding history, dietary history, immunization history. This is the history that you need to know, the other history to complete the history in the patient history. The other developmental history. Developmental history got two things. One is that but before you go, you can present the developmental history, you must understand the parameter or the milestone. The milestone, for example, for the basic milestone. When as you know, they got four things that you have to look into: gross motor, fine motor, vision, hearing and speech, social. Now sometimes people add one more, cognitive. So the progress of milestone, you must know the milestone. Milestone is that you must know that the gross motor, when the patient can turn full, patient can sit without support, sit with support, sit without support, standing, cruising, walking. You have to know roughly where the norms are. When the patient can reach things with one hand, two hand, put things in the mouth, with finger grips. For the fine motor, hearing is when the patient can speech, mini speech lah, cooing, babbles, say one single words. And social is when the patient can recognize the mother, sensory anxiety, and so on. You have to memorize the milestone. No, sorry about that. You have to memorize the major milestone. If you can remember the ADMET formula when you form 5, no reason you cannot memorize this. If you can remember the table, the chemistry table, you must doing your form 5, all the chemical name, all the table, you can remember, you can memorize this. No choice, you have to memorize the milestone. And then when talking about developmental history, two things you must know. One is when they reach the milestone. Second is you must know you must know what the child can do now when the patient comes to see you. You see, important is that they say the patient is 5 years old, but if he can run and sitting now, he can run netbook now. But you found out when you ask the mother, the child can only walk at the age of 3 years. It means that the child still delay. Though when the child can see you now, during that time, 5 years old, the child boleh panjat pokok, boleh panjat all those things. But it means that in terms of the milestone, it's delay. Yes, because by right, you know that the child can walk by the age of 1 year. So important to know when the child reach the milestone. So family history, you have to have the family history, learn to construct the family tree to understand consanguineous marriage, especially when it comes to genetic. When it comes to genetic disease, we will ask you at least to go 2 generations. If not genetic disease, probably we won't ask you so much lah. But come to family history, genetic disease, we will ask you the 2 family tree. Other history, medication history, drug history, medication history, kan drug nanti drug kat data. Social economic history, daily activity and school, environmental, house facility, and so on. Very important about environmental history, especially in, say, asthma. But in asthma, if the child stay in the house where there is a lot of carpets and very dusty house, where are you going to put it? Into the HOPI, into the present illness, or into the district environmental history? Where are you going to put it?
HOPI.
You will put HOPI. Because when we listen, we understand, you assess that already, because that is part of puzzle, because you can tell us why the patient got poor control, because the environmental issue is a problem. So you see, very important you to understand or not. You take all the history. according to the framework whatsoever when we get to you. But when you want to present, you are tukang masak, you are the cooker, you are the you are the cook. I am makan tau. Tengok, so how you present to me, how you susun is up to you. You tak pandai susun, tak menyalurkan, I'm not going to eat. If you susun nicely, I would do menyalurkan. So your presentation. So how you put inside your plate is up to you. It's our creativity. You have to decide which one is HPI, which one not HPI, which one is straightforward, and so on. And there's no straightforward. It's more challenging than we give you all this must be there. It can be very robotic, and very boring. So you are going to present to us how you want it to be. Because after you clock your case, you identify the chief complaint, you listen to the history presenting illness, all those things, you identify the problems, then you want to share to us what you think about the patient problem is all about. You have to convince us. It's on you. The problem of you all is that in your mind, when you come to see the patient, you want to tell us is what other people have done. Apa people make diagnosis, other people tell you about to management, what you the narrative tau. The narrative. That's why if you come to see your patient, you don't know the diagnosis. With the aim to get the diagnosis and to present it to me what you think the diagnosis is different from those who see the case, baca case note, try to clerk the case and try to get the diagnosis sama seperti case note, and then you going to narrate. And we can see the quality. There's nothing but narrative. There's no input from the patient at all, from you all. We know you when it was 20 years of teaching, we know if you clerk your case, you really clerk your case, or you clerk your case based on the case note. We know. The way you present to us, we already know. We don't need to accuse you. You mesti baca case note. No, we don't need. We already know. You open your mouth, the first 5 minutes, we can decide already. This fellow has nothing. Dia baca case note ni semua, and the narrative only. It's not trying to learn about the case. But many of you are doing that. You don't take a challenge to see the case. Even tak baca case note pun. You only baca case note apabila you just settle about your patient. You settle everything in terms of your plan of investigation. Then only you check case notes to see the patient progress. What you think correct, not correct. And then when you present to us, we can figure out, this fellow really try to learn from their patient. Okay, the next thing after you are clerk, you have to go through the clinical thinking. The clinical thinking have to be based on the background of your basic science. No way you can have critical thinking without the background of basic science. There's something that you all I found out that many of you after 2 years struggling, very badly struggling in basic science, when it comes to the third year, many of you forget about the basic science. I don't know why. Sometimes you are more fresh than us. You are learning more than me, basic science. But when I ask you, even the respiratory cycle pun tak boleh explain to me. Tapi before the exam of the basic science, they will explain to you the respiratory burst. Tapi tak boleh after that, because sadly you struggle to learn so much. When you come to basic science, you forget 50% of it or 60% of it will come to us. Very sad, Jangan belajar teruk nak exam part 1 professional. Come to us, forget apa you belajar. Because you need those things to help you to learn in critical thinking. So your basic science, your basic critical thinking is you have to have a strong in anatomy, pathology, physiology, biochemistry, microbiology, or you have to strong all that. And then you can think about how to develop your critical thinking. So you have to ask yourself, what is the problem of the case? Where the problem of the case? First of all, you identify what the problem of the case. Many of you are unable to identify the problem of the case because all along you narrate. So many of you narrate only, narrate saja. Narrate what the parents say or the mother say, you just narrate. So you cannot think, sit down and think what's the problem, where the problem is, when the problem is, what the process is. Is it infection? Is it inflammatory? Is it tumor? Is it endocrine? Which system involved? Which the main system involved? Which the other system that associated with it? Any other system affected with it? Well, is it a chronic case, acute case? Sometimes I ask you, is it chronic case or acute? You cannot identify. Cannot tell me. Then I ask you, how severe is it? You also don't know. You cannot think, oh, is it mild, moderate, or severe? Pun tak tahu. Because you narrate only. Complications of the problems, tak tahu. You don't know what the main problem, how you expect to know the complication of the problem. Many of you also don't know. Because over the time, I found out many of you become more a narrative. Narrate saja, what the parent told you. And didn't critically think about the cases. And then the other thing is presentation. Presentation started with introduce your patients, source registry, tell us the complaint, the chief complaint, and then anything related to chief complaint in HOPI, even during your systemic review. As I said to you, the thing still when, what, why, where, chronological order, severity and complication, the positive history and negative history, which is the same importance, still the presentation. Okay, then you go to systemic review, they're not related with HOPI, the other history and progress in the ward. Progress in the ward, very important. So your history for you all is on your HOPI only until the patient being admitted. Now, remember that. After that, once the patient been admitted to the ward, there will be intervention by the doctors. It's not anymore history of present illness. It is the progress in the ward. Let me be clear of that, because I found out still the same thing happened. I don't know what happened. Well, I told them that when they present, still they present progress in the ward. Okay, let me say again, your HOPI exemptive present illness is only until the admission to the ward. Once what happened in ED is still part of HOPI. But once patient in the ward is not anymore HOPI, it will be the progress in the ward because there is intervention by the doctors on the illness already. So it will be a progress in the ward. You don't need to present that, but when we ask you how the patient in the ward, then you have to tell us day 1, day 2, day 3, what happened in the ward. But that is not HOPI. Because the doctor already intervened to the illness. They progress in the ward. So important, no magic bullet. Practice make it perfect. If you don't practice, you will not get it. Remember that. Practice make it perfect, no magic bullet. The key is to practice and practice until you get it. Okay, for you all, minimum, I would like you present 2 to your lecturer and specialist. If you can get 3, better. 4, much better. Minimum is 2. But 2 actually for your group, I found out you're not fluent yet. Unlike the before years ago. 2 still not able to fluent. But so many of you, so few of us. So I would like at least 2. 3 is is good. But the ratio for you to practice between you and between yourself to get the fluency is 1 in 3. It means that if you present as 1, by right you will present among yourself 3 already. By right, you present 3 already, because to get the fluency, You have to sit down and present to your colleague, and your colleague will see your presentation, comment. Doesn't matter right or wrong, but to get the familiarity of the presentation. And I tell you, during my time, I present much more to my colleague than I present to my lecturer. I present much more because for us to get the fluency, once we get the fluency, we will be confident, because you found out the main thing that you present confident presentation is the more you practice presenting simulation, the better you feel. I remember where I have Prof. Lam last time. No, everybody voting, nak present ready semua kena vote. Nobody dare to present. But once we vote, the patient will practice in front of us first before present to Prof. Lam. Because after that, you got confident presenting. That's how serious we are when we prepare for presentation. Study the case before you present. Many of you morning tu nak present, malam tu work out the case. Of course, definitely you're gonna screw because you didn't study the case. Study the case. The presenter responsible is to know every aspect of the case before presenting. You can usually take 1 week to study the case. Study the case so that when we ask question, you can answer just like that. Because you see how the important to us, we see how serious you are when you present to us. If you prepare ala kadar saja, of course we become irritated. So we know how serious you are. You serious, we serious. You're not serious, we're not serious. So we have nothing to lose. You not become a good doctor, you may fail. You may the patient will not like you. You may have difficulty with your husband, become depressed. And then you blame the system. Eventually, you cannot cope. Okay, anything else? Any questions?
Doctor, I have a question. Hello. Yeah, regarding the sources of history, at what age actually we can get the sources of history from the patient itself, or from sources from the parents?
Sources. It depends on your assessment. Because our children until 12 years old pun ramai tak matang lagi. You'll be surprised. Like you, or even you all pun ramai tak matang lagi until now. To wait to offer matang very difficult. Lama lah. Very difficult. I found out until 12 years old ramai tak matang lagi. Even the patient, the child doesn't know what's happened to them because the mother very protective. So it depends. Some children, they are mature enough, even you can get nice histories. Some parents, some patient, but patient because until 12 years old, unlike where in overseas they have adolescent ward and the pediatric, they can go until the age of 16 or 17. And then you found out that by that time they are fairly mature. In Malaysia, 16 years old, sometimes they don't that mature. You still need parents to give the history. So your assessment, you have to decide. But for us, if you ask me, 90% of children, 95% children below 12 and below, they still are able to give you good history. They're able to give you good history because communication is not part of our culture. How many of you masa kecil-kecil diajar to communicate? Tak ada kan? Tu tahu pandai sendiri kan? See, you pergi Mak Saleh punya ni, communication is part of their curriculum. Sebab tu ada banyak aktiviti, communicate, cakap, public speaking, choirs, menari, everything, semua nyanyi, semua depan, because they want to build the confidence of talking and communicate. But our strategy is the first thing is to pass exam. Betul tak? Make sure exam score is good score. Must have a good score in is. So the different perspective. That's why the communication skill is not part of our culture. Unlike other people, they focus on communication skill. So you have to assess lah. Okay, anything else?
Doctor, I have a question. In the other history slides, you mentioned one point about the feeding or dietary history. So I would like to know what kind of history should we get for patient and what's the
Dietary
significance of
history is that, let's say what you take the child is taking now, when the child, if the child let's say is besar dah, when they start the weaning, then what the current they take, usually after 1 year, we expected them to take adult diet same with their family member. So anyway, it depend the how detailed is it depend on the case. If the case is malnutrition, failure to thrive, of course we will expect it to become very detailed. If the child is asthma, asthma case not problem of body, then as long you say to us, oh, the child is taking adult diet similar with other family member, then it's okay. We accept that. But you must realize that there are many children are picky eater, even asthma patient. So there are theory about asthma with hypocalcemia, and then many of patient children are picky eater. It's nice if you can identify those picky eater, though it's not related with chief complaint. Anything else? Okay. Okay, mana tu? Iqmal, mana Iqmal? Ada dua orang ni. Iqmal, kenapa you punya system out? Iqmal? Lokman, Iqmal ada tak?
Tadi saya WhatsApp dia, dia kata dia tumpang dengan seorang lagi brothers.
Okay.
Saya
Kenapa terus sangat ke sana dekat tu?
Hello.
Hello, doktor.
Terus sangat ke you punya tu?
Yes, doctor. I'm sorry for the trouble just now.
Tak apalah. Okay. Your start your posting ni. Okay, your punya next week jadual tak siap lagi in a way. Nanti we try, okay, besok akan cuba siapkan, because we're not sure how many in the host staff going to join the teaching. Okay. Okay, anything else? Tak ada ya? Okay. Kenapa tak boleh lift ni?
Thank you, Dato.
Thank you, Dato.
Tak boleh
Thank you,
lift?
Dato.
Thank you, Dato'.
Thank you, Dato'.
Thank you, Dato.